Hello, everybody. Welcome to a new episode of the Dissenter. I'm your host, as always, Ricardo Lopes, and today I'm joined by Dr. Lars Sandman. He is Professor of Healthcare Ethics at Linköping University and Director at the National Center for Priorities in Health in Sweden. His research area is organizational ethics in healthcare, focusing on priority setting and ethical analysis of healthcare methods. He is the author of A Good Death on the Valley of Death and Dying. So, Dr. Sandman, welcome to the show. It's a pleasure to everyone.
Thank you, and thank you for having me. It's interesting to take part in your very good show. So, thanks.
Thank you. So tell us first perhaps a little bit about organizational ethics, what it is about, and how it applies in the context of healthcare specifically.
Yeah, thank you. Organizational ethics, for me at least, has two parts, you might say. One, and perhaps the more formally correct in relation to the concept, is that organizational ethics is interested in how to basically organize an institution in order to support well-founded ethical sort of actions and attitudes, etc. And of course, in this case, the institution is the healthcare system. So, how can you develop routines, guidelines? How do you organize ethical reflection, ethical councils, ethical advice, etc., in terms of organizing the healthcare system to support ethics? But for me, it's also sort of another aspect of this, and that is how do you make ethics sort of relevant for the organization you are working for? So in my case, the healthcare system, how do I make ethics relevant? I come from philosophy, and a philosophy can be a very abstract area. Discussing also ethical issues in a very abstract manner. But for me, it's always been sort of very important to try to find a way to do ethics that's actually relevant for the decisions and the problems that the healthcare system are facing at the moment. And I've been involved a lot as an ethics consultant. So for me, that part of sort of organizational ethics, or that aspect of organizational ethics, is also a very large part of my research and my activity as a professor.
Mm-hmm. So I think we can say there are several different approaches we can have to healthcare. Could you tell us about some of them, starting with person-centered care?
Yeah, person-centered care has been a strong, you might call it, trend in healthcare for a number of years, since perhaps the mid-90s or something like that. And then we started, I think, to talk more in terms of patient-centered care, and that has sort of moved into person-centered care. And I said something about that difference. And I think we can see it as a reaction, and a sort of ethically well-founded reaction to a sort of paternalistic and reductionist healthcare system, where I think many patients perhaps didn't feel that they were in the center of the healthcare system, but rather other things were in the center of the healthcare system. So that was sort of a reasonable, well-founded, sort of from an ethical standpoint, reaction to that kind of system. And what do we mean by person-centered care? Well, basically, it is a bit difficult to pinpoint because there are many different definitions of person or patient-centered care. There are many different ideas about where is sort of the basis of person or patient-centered care. But basically, it is the idea that we should start from the patient or the person and the person's values, experiences, preferences when we do healthcare, and we need to know something about the patient, and the patient narrative, for example, is an important part of the person-centered care, to actually listen to the patient story, take as a starting point the patient story and experiences and preferences and values. And of course, shared decision-making has been sort of part and parcel of this also, so that's also an important aspect of this. We tend to think about person and patient-centered care as more holistic. So instead of just taking an interest in sort of the biomedicine or the biology of the person, we also take an interest in the social aspects, psychological aspects, existential or spiritual aspects of the person. So sort of a broader perspective on the person. Then, as I said, there are differences. I mean, people who emphasize patient-centered care maybe emphasize that, well, as a healthcare system, we only have a limited role in people's lives, so we should only focus on the things that we can do. So maybe we don't take a full holistic perspective. We take it sort of the perspective of this being a patient to start from that, while the person-centered care might have a sort of a broader take here and take an interest in the whole person, and also perhaps have a different basis to some extent. So I mean, there are differences, but there are also similarities. And as I said, a strong reaction to what is experienced as reductionistic or paternalistic healthcare systems.
Mm-hmm. But I mean, this person-centered care paradigm is the dominant one nowadays.
Well, at least in at least in communications. I mean, if you look at Western healthcare system, if you look at the WHO, etc., they are emphasizing person-centered care to a large extent. If that actually has taken sort of hold in the healthcare system, if the healthcare system actually have changed, I mean, that's to some extent another matter. I think it is working its way towards a more person-centered care, but of course, a lot of healthcare and a lot of healthcare system, a lot of parts of the healthcare system are still not very person-centered, but still sort of focused on the biomedical sort of perspective, the doctor's view, etc. So I think there's a lot to do, but at least, I mean, it's part of the official ideology, you might say, of most healthcare system nowadays. Yes.
Mm-hmm. And what is personalized medicine?
Well, personalized medicine might sound something very similar to person-centered care, but I mean, to a large extent, it's very different. And nowadays, I think we tend to avoid the term personalized medicine, and instead we talk about precision medicine. So precision medicine to personalized medicine is the idea. It has a similar take as person-centered care in the sense that they do deny that one size fits all. So it is individualistic in that sense. But the personalized medicine or precision medicine is about targeting or tailoring biomedical treatment to a large extent to the individual sort of biological makeup of the person. So based on sort of genetics and epigenetics, etc., try to find how do we tailor treatment in order to give the sort of best biological or biomedical outcomes for this individual. I mean, generally, treatment has been developed through, well, at least ideally through large-scale randomized controlled trials. So we have some kind of statistical idea about this. This will sort of statistically help a patient with this condition, but how it would actually help an individual patient is, of course, to some extent different, because there's a span of patients having different conditions, of course, different variations. So precision medicine is trying to targeting treatment to the individual to a large extent. Yeah.
Mm-hmm. So person-centered care and personalized medicine, are they at conflict with one another or not necessarily?
Well, I mean, not necessarily. I mean, as I said, they do have a similar take in the sense that they try to avoid the standardized patient or the standardized person, or doing something standardized for patient, and trying to individualize and trying to sort of find the size that fits the individual patient. But I think they can be. I mean, just using the same sort of concepts, person-centered versus personalized, might of course signal that they have the same basic value. But in a sense, precision medicine or personalized medicine is perhaps even more reductionistic the traditional medicine, because they try to find the specific biological model for Ricardo or for Lars, and try to adapt treatment to that. So in that sense, it's of course highly reductionistic, you might say. And I mean, it doesn't really matter to personalized medicine or precision medicine what you think or what you value or your preferences or your existential ideas about the world, etc. That's of, you might say, no interest to precision medicine. And I mean, even if you're unconscious or even if you don't have any, can express any preferences, precision medicine can still come up with the best treatment for you. Whilst person-centered care is, of course, highly interested in your preference. It leaves room for autonomy. It leaves room for your values and your take on the world. So in that sense, they can be at conflict. And to some extent, if we think that a good reason for person-centered care is that we cannot agree on what's best for you. So we need some kind of dialogue or negotiation about that. We need to know things about your values and preferences. Whilst, I mean, in precision medicine, you might say, well, regardless of what you think about this treatment or regardless about your values of this treatment, we know that this will help you in this way and this will not help you. So you can sort of say you want this treatment, or you can say that I have an idea that this used to help me. Well, we can show that it doesn't because of precision medicine. So I mean, there might be a conflict here, and I think there are other interesting aspects of this too. I mean, if you look at something like responsibility, should we take sort of responsibility and be made accountable for the choices we make, etc. And of course, in person-centered care, that's could be part of the discussion, and we could end up in our sort of dialogue that, yeah, I based on my strengths and weaknesses, I should take responsibility or be accountable to this extent, etc. But in precision medicine, we might find, for example, that in your case, it doesn't matter what you do because you will end up in this health state anyway due to genetics. Or the other way around, we might say that, well, since you have this genetic makeup or epigenetic features, maybe you should be more careful about not drinking or not smoking or exercising, etc. And if you don't, you have that information, you will be at higher risk of developing, well, cardiac problems, for example, or diabetes or cancer or something like that. And that information could be sort of used for the individual to be sort of made accountable for her or his choices, which, well, perhaps go at odds with some of the discussion in person-centered care, etc. So I think there are at least, perhaps not a conflict, but at least potential tensions between these two concepts. And of course, personalized medicine or precision medicine, as I think we generally call it nowadays, is also a very strong trend in healthcare nowadays, and especially in healthcare research or biomedical research. So, yeah.
When it comes to precision medicine, do we already have enough knowledge, and is there support for medicine to move toward it?
Well, I think that there is a strong hype concerning precision medicine nowadays. I mean, it's sometimes portrayed as the savior of healthcare, and especially when we talk about healthcare resources. I mean, if we could target treatment so we don't waste treatment on patients where it doesn't work, that would be sort of a better use and more effective or productive use of resources. So, I mean, there is a lot of hype, and there's a lot of money poured into this in research-wise. There is a lot of development, and there has been a lot of development, and we are seeing, I would say, the first treatments in precision medicine, some of the genetic treatments in precision medicine. So I think there is a strong development. I think, I mean, we're not yet there where we have the full knowledge, of course. So, I mean, we have started that road. And I think something that is lacking here is the ethical discussion and more philosophical discussion. What will this imply for the healthcare system? As I said, nowadays it's more of it's a lot of hype, and there's a lot of kind of hallelujah moments when we talk about precision medicine from different perspectives. I mean, both the pharmaceutical industry, from politicians, from patients group, from the medical professionals, etc. But I think there are issues we need to discuss further. For example, when it comes to priority setting, what will happen? For example, let's say we have a patient group, we have treated them with a specific treatment, and now we get this new diagnostic test where we can see that, yeah, for this 10% we will have a good outcome. For these 90%, we will have, well, some kind of moderate, not very good, but we will have some effect, but not that good effect. How should we deal with that? Should we stop treating them? Should we give them the treatment anyway, but with less resources? There is a lot of issues here. We will also have perhaps a situation where we will have smaller populations, of course. And what about evidence there? How to treat that? We can't do these large controlled randomized trials because we are focusing on precision medicine. So we have a sort of biological model for why things would work, but we don't have any actual studies perhaps. So we need to relate to that. Are we willing to risk investing resources in this kind of treatment, and what will happen then? So I think there are a lot of ethical, philosophical, sort of methodological issues to explore in relation to precision medicine. So I think we as ethicists have a task to do there, actually.
Mm-hmm. So you mentioned at a certain point there priority settings. Could you tell us more about that? What are healthcare priority settings, how they work, and what kinds of issues do they help us solve or deal with?
Yeah, well, basically it's about the fact, I would say, that the resources for healthcare, regardless almost how much resources we sort of pour into healthcare, it seems that like there is always a gap between healthcare needs or what we want the healthcare system to do and the actual resources we have available, both in terms of financial resources, but also, of course, in terms of staffing. There are, at least looking only at Sweden, where I am, we have projections where some argue that, if we follow the trends, the development of demographics, of the fact that we have new treatments and higher expectations from the population, a large number of the Swedish populations, perhaps 50% or something like that, would have to work in the healthcare system in 50 years or something like that. We would find, of course, ways to handle this, but it's just projecting what we're doing right now, and that's, of course, impossible. So I think then we need to do sort of a distribution of the resources, and of course we will have to do that anyway. And when we talk about healthcare priorities, I think we are interested in finding ways to do sort of fair, equal, just distributions of healthcare. So it reflects back on or we have to take a starting point then in our distributive theories of justice. And there is a discussion, has been a discussion on that for a number of years, generally, and also in the healthcare system. So, and of course, this is relevant on all levels of the healthcare system, all from how much money should we pour or use for healthcare in relation to something that is, of course, very highly on the agenda now, the defense system or the school or other parts of the welfare system, how high taxes we should have. And then, of course, what kind of sort of patient needs should we focus on? What are the most pressing patient needs, or what are the patient needs that should be given the highest sort of priority, and how should we deal with different treatment? How much resources should we spend on different patient groups, etc. So, we find these issues on different levels of the healthcare system, and I think it's important to emphasize that all of these issues are highly sort of are value issues or ethical issues. It is about ethics and values. It's not sort of technical issues on how or strictly economical issues in terms of how to distribute resources. But we also need to discuss them things like, what kind of principles should we have to distribute resources? Should we have a needs-based healthcare system, for example, or should it be more of a demands-based system. If we have a needs-based system, how should we interpret need? What is need? Many would argue that it's sort of a combination of both the severity of a condition and also the capacity to benefit. So how do we balance between severity and capacity to benefit if we need to do a priority? The issues of cost effectiveness, I mean, how should we enter that into the picture? Should we, for example, have make references to people's responsibility or accountability? I mean, an issue that has arisen during the pandemic. If I choose not to take the vaccine and I get COVID and end up in the ICU, and of course that's extremely resource demanding, and I take the sort of the bed from someone else that perhaps in need of ICU, should that be taken into account? Where should we draw the level for the healthcare system? Should we actually have to handle some of the healthcare needs on our own, et cetera, et cetera? So there are a lot of I would say, rather pressing and important ethical issues here that we need to address, and that has been the focus for the last few years of my own research and my own sort of consultancy work in ethics in the Swedish healthcare system.
Mm-hmm. So to talk about a specific example, do you think that plastic surgery should be publicly funded?
I think that's an interesting example, because that tends to be, at least in many publicly financed healthcare system of what we call welfare type, seems to be kind of a borderline issue. I mean, you find, I would say, very few healthcare systems that take in all of plastic surgery into the publicly funded system. Yeah. And I think we find also very few systems that don't have any plastic surgery within the healthcare system. And that raises the kind of priority problems that I've talked about, that we need to find a way to distinguish which kind of plastic surgery. Can we do that? Can we find a way to distinguish which kind of plastic surgery intervention should be part of the publicly funded healthcare system and what should not? And of course, we could use more general aspects like the severity of the condition. How does it affect the person? I mean, there are conditions that needs plastic surgery that are actually leading to premature death. I mean, some kind of skin cancers, perhaps, etc. Or how does it affect quality of life, and also things like how effective is this plastic surgery intervention? What does it actually contribute to in terms of patient benefit, etc.? So, I mean, we can use the traditional or the concepts or the aspects that's used normally in priority setting. But we did an analysis. I did an analysis together with a plastic surgery surgeon a few years ago, and we tried to sort of relate to how is it dealt with in today's discussion. And a common distinction was made between what they call functional and non-functional problems. So functional problems is problems in need of plastic surgery that in some way affect the functioning of your body, to say. I mean, let's say you have your breasts are too heavy, so you have so it causes back pain, for example, and you have a functional problem. Or if you have a cleft lip, that means that you can't really eat or digest food or chew, then you have a functional problem. The idea was that functional problems should be publicly financed, and then, well, basically a non-functional problem should not. But we argue that, I mean, there is something to that distinction, but we argue that some of the non-functional problems seems to cause a lot of problems with your health, or your mental health, or your psychiatric health. And it seems like the quality of life for things that is about appearance, we might call aesthetic problems, still have a large impact. And it seems strange to draw the line. I mean, a minor functional problem might be less of a problem than a large non-functional aesthetic problem. So we try to make a distinction there and try to argue that we need to look at other factors than the decision between functional and non-functional. We have to look at things like the severity of the condition, how much does it actually affect the person. We have to look at how effective is plastic surgery, of course, to actually address the problem. And then we also modulate this in relation to what we call statistical normality. I mean, when we talk about a functional problem, what is a sort of normal function? We generally take as our well, we take the population in the country and see what is called a kind of statistically normal functioning of the population, and that will be some way our guidance for how much should we do in order to restore normal functioning. And we argue that perhaps you could think something similar when it comes to your appearance or aesthetics. So if you have if your looks is very, understand me correctly, deviant from the normal population, statistically, it's very seldom found, and people have problems with this look. That could be something that actually needs public funding to get help with. Whilst if you have, I mean, if your nose is a bit crooked, and it's kind of common in the population to have a crooked nose, people have all sorts of noses, and it seems, I mean, it's not something that's uncommon. Maybe that would actually give less room for public funding. So we try to sort of find an instrument to actually work with in the current healthcare system to distinguish between what should be publicly and not publicly funded. And I think analysis like that could do some help to actually sort of bring the system forward in this discussion, especially finding a way which is perhaps more consistent or less up to the individual doctor, in this case, individual plastic surgeon, to decide what should be in and what should be out. And when we did this article, we found that it is interesting in the actual system to find that when you have started on doing plastic surgery on someone, you tend to reach for perfection, at least in the Swedish system. So you do more and more interventions in order to reach perfection, instead of finding sort of this is satisfying. If you need sort of perfection, you have to pay for it outside the system, and instead spend these resources on other patients that's in need of plastic surgery. So we found some strange priorities here, and I think there we as philosopher ethicists can do some good actually in actually analyzing, pointing to discrepancies or inconsistencies in the system and try to find better ways to think about these issues.
Mm-hmm. When it comes to developing health policies, do you think that there's justification for patient involvement in that?
Absolutely, I would say. I mean, if we think that, at least, I mean, we live in a democratically run society, and where healthcare is part of the democratically run sort of welfare system, I think there is a strong democratic reason, of course, that anyone who is affected by a policy decision, and in this case a policy decision in healthcare, should in some way be able to influence that decision or involved in that decision making. And of course, patients are highly affected stakeholders in the healthcare system. So from that perspective, I find that that's sort of almost a no-brainer. I think the challenge is, how should they be involved? How should they affect the healthcare system? I mean, in this trend we talked about earlier about person-centered care, I mean, there is a focus on starting from the patient. And I think to some extent that's also important when we talk about policy. So, I mean, there's no use for us, if I take on the policy sort of path right now, as policymakers, to do policies that no patients would actually appreciate or find relevant or find beneficial to them or find that address really their problems. So in some ways we have to start from the patient. What is the patient's problems? What do we need to actually deliver from the healthcare system to address a specific patient population's problems? So from that perspective, I think, I mean, it is essential to have the different patient population, the patient perspective in the from the starting point in a sense. But I also find that there are challenges, especially when we do priority setting, which is sort of my expertise. Since when we are sort of making policy decisions about specific treatments or specific interventions or specific changes, they are often of the character that they will benefit a specific population. So let's say there's a new treatment for a specific cancer. So if we decide that we will introduce this specific treatment, we will cause an extra cost for the system. And if there's an extra cost, there's an opportunity cost. So someone has to, of course, pay that if the budget is fairly the same. And the problem in the policy decision is that it's, of course, easy to identify the population that will benefit from that. We take a person from prostate cancer if it's a drug or something for prostate cancer. But it's much more difficult to find how do we represent all the patients that might suffer or will suffer the opportunity cost in that specific policy discussion. And that has caused some discussion, I think, and I think we need to be a bit careful to think that if we just have a patient from some patient organization, we have the patient perspective represented. That is not necessarily true, because different patients obviously have very different perspectives, and especially if we take person-centered care seriously, it might even be different on an individual level. So different patients having the exact same diagnosis and perhaps having the need of the same treatment might still have very different ideas about what treatment they should have or what treatment should be prioritized, etc. So I think we need to be a bit careful when we talk about and distinguish between, are we talking about more general policies like how should the healthcare system be organized in terms of primary care or hospital care, and where should the focus be, etc. And we talk about general principles for how to develop healthcare. Then I think the patient perspective is extremely important. When we talk about specific treatments and the policy how to do this, but we should introduce a specific treatment, I think we have to be a bit more careful in how we introduce the patient perspective. I think it's still important to have a dialogue. It's still important to have their perspective on that specific treatment. But we also have to understand then as policymakers that we are sort of representing the system and we are representing other patients. And we might also have an interesting conflict between sort of the perspective of individual interest groups, if I might call it that, and ethical principles. So just to take the Swedish examples, in Sweden we did in the mid-90s decide on ethical principles in the legislation for how to prioritize treatment. So we have three principles: a human dignity principle, a needs solidarity principle, and a cost effectiveness principle. And we are bound by legislation to follow these principles, and they express a sort of a needs-based or prioritarian view on healthcare distribution. So we take into account the severity of the condition, we take into account to what extent we can benefit patients, and we take into account cost effectiveness, and we make like a balanced decision on that. And of course, we might end up in a situation where we, on good grounds, based on the ethical principles, say no to a new treatment because we find it not cost effective enough in relation to the severity of the condition. But where the patient representative for that group still wants the treatment and wants to try to influence the treatment to be introduced. And that is an interesting conflict. How much, should we actually stick to our ethical principles, or should we allow a specific interest group to influence the decision? And of course, the patient interest group might be very interested in influencing the decision, even if it goes against the specific principles in this very situation. On the other hand, for the legitimacy of the system, it might be more important that we actually stick with the principles that we have decided on. So I think there are, also conflicts here, or potential conflicts, or potential sort of value or ethical tensions that we need to be aware of when we talk about patient representation or patient taking part in policy decisions.
Mm-hmm. So here we were talking about policy decisions, but when it comes to their own medical decisions, to what extent do you think patients should be involved in them and how?
Well, I think they should be involved to a large extent, and I think that follows a bit from what we talked about earlier, the person-centered care. I mean, if we and there are different ethical reasons for this, of course. I mean, one is the idea that we should, give room for respect, patient autonomy. We think that the patient's perspective is sort of important to take into consideration by its own right. So that's one part. But also because we are supposed to do good for the patient, and we're supposed to avoid harm for the patient. And I mean, the first starting point is, of course, to know what is good for the patient, what is harm for the patient. And that's not necessarily we as outsiders or the medical doctor or the nurse or the physiotherapist can decide on before actually allowing the sort of having a dialogue with the patient. So in that sense, we need to start with the patient, start with the patient's perspective. So in that respect, the patient needs to sort of influence the decision. That might not be perhaps true in all situations. Some situations might be so obvious that we perhaps don't need to ask the patient, what do you think in this situation? I have this experience. I suffered 10 years ago a myocardial infarction. So I went into a hospital by ambulance, and I faced the doctor, and he asked me, so what are you doing for a living? So I told him I was a professor of healthcare ethics, and he straightened up and it sort of got a bit more serious, and he started informing me about all these ways he could treat my infarction. But he said, I mean, there is one standard, sort of best standard treatment, but there are also other treatments if you want to choose them instead. And for me, in that situation, that kind of offer to me, I mean, I didn't need that. There was a standard treatment. He had no reason to expect that I wanted suboptimal treatment. I didn't express any specific values or ideas about not wanting the standard treatment or having any religious ideas or cultural ideas or whatever for why I didn't want that. So in that situation, I think maybe he was a bit overcompensation in a sense or overdoing it in a sense. Well, in other situations, it's a perfectly reasonable question to ask what is important and start there. And especially in chronic care, people might have a lot of experiences and they are used to handle their own situations and they have been trying different treatments and have experiences of that. So I think we should allow patients to a large extent to influence treatment. And I think when I say that, it's also important to make a distinction here. What should they influence? Well, they should, of course, to a high degree, influence the goal of care or the objective of care. But they are not perhaps as well versed in actually understanding the best means to that, because that's sort of based on professional experience and professional knowledge. And I find sometimes when I discuss this with clinicians that some do tend to sort of mix up this and think that, well, if we should let the patient decide, should we let them choose whatever means to this goal they want, even if it's suboptimal? And I would say that, well, that sounds to me very strange. And I mean, if I as a patient express that I want to be helped with this, I have this balance between, for example, survival versus quality of life, then the professional is, of course, best placed to say what is the best means to that balance between survival and quality of life. I, as a patient, is probably not very well versed in that. I can still, of course, and I should be able to say no to treatment, even if it is the best means. I can have a lot of course, reasons for doing that. But so I think we need to be a bit careful when we say that we should have a lot of influence as patients over the clinical decision. But basically, yes. I mean, we are doing healthcare for the patients. We are not doing it for someone else.
Mm-hmm. So in healthcare and medicine, many times, probably most of the time, people have to make decisions based on cost effectiveness reasons. When it comes to that, are there differences between withholding and withdrawing treatment for those same reasons?
Yeah, that's an interesting question, and we have a doctoral student exploring that at the moment. A few years ago, that came up as kind of a problem in the Swedish system. We do make reimbursement decision or policy decisions about new drugs on a national and regional level. And in some cases, when we made a decision about, well, saying no to new treatment because it wasn't cost effective, some patients were already on the drug for different reasons, because they had taken part in a clinical study, or because they had perhaps taken part of a compassionate use program, or for some other reason they were already on the drug. So the question arose whether we should withdraw treatment for those patients, and when we say no to new patients, or should we simply accept the inequality here? And we found that the difficult to withdraw, because there seems to be at least a psychological difference here. People tend to view withdrawing treatment as sort of much more psychologically worse, and perhaps also they find that it's ethically worse than withholding. But we found that not only led to sort of unequal treatment for patients with the same conditions, it also led to some clinicians, clinics not wanting to go into clinical trials because they fear ending up with having to treat all these patients at a high expense, for example, after the clinical trial had been terminated or finished. So it seems that there was actually a problem here. And there has been quite a lot of discussion about withdrawing and withholding treatment in other settings, for example, when it comes to ventilators in the ICU or the emergency room. And most of these ethical analysis has ended up in the conclusion that it's difficult to find an ethical difference between withdrawing and withholding treatment. So, I mean, you have two patients. They have the same condition. They have the same, perhaps, capacity to benefit. One is already on the ventilator or the drug, and the other is not. And we say no to this patient. So it's difficult to find any sort of strong reasons, perhaps, to say not to say no or withdrawing from the other patient. So we did an analysis of that in relation to cost effectiveness. And I think psychologically it might be even more difficult for a doctor to say no and withdraw a treatment that when the reason is not lack of effectiveness or that we only have one drug and we have two patients, but where the reason is sort of economics or cost effectiveness, that it has an opportunity cost that's not acceptable. So from a psychological point of view, it seems like it's difficult. But from an ethical point of view, we find it difficult to find any strong reasons. So we did an analysis. We looked at the doing, allowing distinction. And it seems, if we look at the previous discussion on doing and allowing, that both withdrawing and withholding would end up on the allowing side rather than on the doing side, because it's an underlying condition that actually causes the condition of the patient. We looked at, could it be argued that, well, in the case the patient actually has a drug or a treatment, the professional or the doctor in some way has promised this to the patient, or there is a kind of an agreement that this should be the case. Well, that could be true, of course, but I mean, absolute promises are not something we can use perhaps in the healthcare system. Also, a promise has to be balanced against other considerations. And it's difficult to see that you have a stronger duty towards a patient that's already on a treatment than a patient that is still within your care but doesn't have access to the treatment yet. So we didn't find any strong reasons for that. And then we look at consequentialist reasons. Of course, if people find that it's more difficult to terminate or withdraw treatment, that should, of course, be taken into account in the consequentialist analysis. But at the same time, we have to understand that if we say no for cost effectiveness reason, we do that for consequentialist reasons. We do that because we find that these resources can be better used somewhere else in the system for other patients. So we had difficulty to find any strong sort of ethical reasons. Then there is a discussion about, because much of this reasoning builds sort of on the assumption that sort of equal patients should be treated equal. And there is a discussion, can we actually say that they are equal? So for example, maybe a patient that is on a treatment, there we know whether this is working or not, and we have more past knowledge about that patient than when we have a patient where we haven't tried the new drug on, etc. So there might be differences that we need to take into account. So at the moment we are exploring this from a more experimental perspective. So we're doing interviews with doctors and patient representatives to get their views on this. And we find that the distinction doesn't seem to go between withdrawing and withholding, but there are other factors here that seem to play a role. And then we are doing experimental studies to test whether the findings, how do people react to these situations under different context or contextual factors. So, and that's also part of an approach to, you might say, organizational ethics, what we call empirical ethics, where we find that, well, a strict theoretical analysis might end up with a certain conclusion, but maybe that's not very useful in the to actually make a policy for the actual clinic, because people's psychology doesn't work in line with the theoretical analysis. So we try to combine the theoretical analysis, and then we do empirical studies and see how do we need to modify the theoretical analysis to end up with clinically relevant guidelines that people can actually follow in terms of, and with actually I mean that is supported by their psychology or their sort of strong values and things like that. And I think that is also something that's important when we talk about ethics in healthcare, and the take on organizational ethics I described at the outset. That we as philosophers are, of course, extremely good at doing sort of consistent theoretical analysis of a specific question, but they might not be of much use if they don't actually take into consideration how is the context working, how are people functioning, what kind of values are out there, and we might have the idea that we try to sort of change those values over time, but until we have done that, we need to address the problems in a way that will actually work in the situation. So I find that interesting and challenging, and even if I'm a philosopher, I'm a theoretical guy. I take an interest in these more empirical sides of ethics, which I find very important and interesting. And I mean, there's been a strong development of, for example, behavioral economics or behavioral psychology that I think is valuable input in our work as ethicists or philosophers.
Mm-hmm. So for this last part of the interview, let's talk about what is perhaps the most extreme case of medical decision making that involves death and end-of-life decisions. So is there such a thing as a good death, and what would that be?
Well, I think there's sort of a multi-layered question you asked there, because I mean, you might ask, is there a good timing of death? I mean, is there a good sort of place in time to die as an individual? That's one question. Another question is there something like a good dying? Is there a way to actually finish your life before you die, and how should that be characterized? And of course, if you're sort of interested in metaphysics, you might ask if there is something good after death that might happen. But I will leave that aside. I don't have much to say about that question. I think we can. We can have an interesting discussion, of course, about the good timing of death. And I mean, a standard answer would be perhaps to say that, well, a good death is a death that occurs when the future holds only on balance, bad things for you. So on balance, the future will not add any more quality of life or no meaning of life to you as an individual. When that occurs, it's of course a difficult question to answer. Especially, I mean, it's also has its epistemological aspects. I mean, how do we know? How do we know how the future will actually play out? I mean, it might look bleak for the next 10 years, but maybe then things scale up and I find something to that actually brings meaning. So of course, I mean, practically it's difficult. From a theoretical view, you could argue that is the sort of best timing of death, and I think there is something to that idea. From an individual perspective, on the same time, you might ask if we then take kind of a societal perspective, what is the best timing of that? And that's perhaps a more difficult question. So, I mean, it is argued, I don't know if it's true, but I mean, some people say that the first 200-year-old guy is already born. I don't know. I have no idea. I think I remain a bit skeptical until I see the evidence of this. But anyway, I mean, if we could sort of radically prolong life, I mean, things might change. When is the best time to die from an individual perspective? Because that would probably imply that things like different diseases would I mean, I wouldn't be affected by disease if a lot of my fellow friends also lived on for long. I might not be sort of fed up with life because I'm lonely and no one is left in my generation, etc. But it also gives rise, of course, to questions about what would happen with society if that would happen. I mean, if we could radically prolong life, is it the fact that we will end up in a stagnated society? People like me, old guys, will sit on their professorships at 150 years and not allow anyone to take my place. I mean, there is a sort of a kind of a natural generation shift in terms of having a limited lifetime, of course, and that probably gives rise to creativity in society and gives us an opportunity to change things. I mean, sometimes it's argued, we have to wait until the old guys die before we can change things. And maybe there is something to that. So I think if that opportunity would happen, or we would have that opportunity to prolong our lives as human beings, I think we need to change the way we think about society and about our lives and our careers. And maybe we need to change over time, etc., etc. So I think there is a lot to this, but that's of course a more futuristic take on this. But I think generally you could at least talk about some kind of good timing of death. When we talk about good dying, I think in a similar way, I think we could, even if sort of arrive at a timing of death that's not ideal for me or not the best for me, I could still make the last period before death as good as possible, at least. And that, I mean, I started doing this, and this was my PhD thesis once upon a time, and I was a bit provoked, I think, when I realized that there were some rather strong ideas of how you should go about your life at the end of life, that you should prepare for death, that you should reconcile or come to terms with death, that you should try to fix your relationships before you died, etc. A lot of ideas, strong ideas of what to do, and I think many of these ideas were found or based in a religious worldview where it actually made a difference for the afterlife what you did before you died. So, and my challenge was then, could you actually find something in these ideas? And I tried to analyze that from a sort of theoretical value perspective. And I think my conclusion then, and to a large extent, I think that still holds, is that, I mean, obviously things can be better or worse in dying, and you can do things. And some of these ideas about reconciling might be beneficial to you. I mean, if you reconcile, maybe you experience well-being to a large extent, and if you fight all the way into your death, so to speak. And of course, if you have had bad relationships, I mean, maybe it's a good thing, or it is probably a good thing to try to sort out those relationships, ask for forgiveness, not at least for those who remain in life, etc. At the same time, I found a lot of examples on people who seem to be, and a strong argument that from an individual perspective, fighting all the way might be actually more in line with your personality and your values and your preferences. And if we have this idea that we should sort out relationships just before we die, I mean, we have even stronger reasons to sort out our relationships right now than wait until we die. And also, I mean, there's also this strong idea that I want just to live my life and then I die in my sleep at old age. So the idea that we shouldn't be able to prepare because we shouldn't know when we die, etc. So I think I ended up in a rather individualistic idea about what is a good death that might be different for different people. With that, having said that, I think still it's important we could take comfort. We could find guidance in traditions. So, I mean, if I'm dying, I could at least consider the idea whether I should reconcile or prepare, but I could also discard it and still do sort of a good dying, I think.
Mm-hmm. So, do you think then that, particularly when it comes to medical decision making involving death, it should be up to the individual to decide when he or she should die? I mean, when and how he or she should die?
Well, yes, I think, we do have that opportunity already, of course. We can commit suicide, and of course I can decide to do that, and I can do it in different ways, etc. So in that way, we have already the right, so to speak, and at least in Sweden and in most countries, it's not illegal to commit suicide. So we have that right, and I don't find any. There might be ethical reasons against committing suicide when thinking about my family, etc. That might cause them harm, etc. So in that way, from an individual perspective, of course, there might be reasons for not committing suicide. But I don't find any, and that is, of course, that I have a sort of secular view on life. I don't find any strong views, sort of strong arguments for not having the right to commit suicide under specific conditions. Another issue is, of course, should I expect someone to help me to die? The question of euthanasia or the question of the healthcare system should help me to die. And of course, that's a more complicated question when you sort of involve someone else to help you to die. And at the same time, I think, my considered view on this is I think there are rather strong arguments in support of some form of assisted dying in healthcare. And I think if you start with this person-centered care, if you find that there are strong reasons to sort of start from the patient's perspective, and I should be able to sort of decide on my life and what is important for me, that's a strong prima facie case for also euthanasia or assisted dying in some form. Under the condition that you could arrange it or organize it in a way that doesn't lead to unexpected or unwanted side effects of this system. And I think still we can see examples in the Netherlands and Belgium and other countries where they have succeeded in organizing this in a way that seems to be able to actually control much of the fears related to assisted dying, assisted suicide, or euthanasia. There are, of course, differences between assisted suicide and euthanasia. Someone would argue that assisted suicide might be less complicated because it's still me who's doing the actual intervention or do the actual act. Euthanasia actually, of course, requires someone else to do the act. At the same time, we do a lot of things in healthcare that stops people from living anymore. We terminate treatment, or we abstain from giving people treatment. die as a result. And I've never been very much convinced by these sort of distinction about the intentional or active passive distinctions and things like that. So I think in general there are strong reasons to introduce a system like that, under, of course, the condition that it can be controlled, that there's a revision of it, that there are checks and balances, so to speak, in order for the system not to have negative consequences. And I think just looking at Sweden, Sweden is a very secularized country, so you might be a bit perhaps amazed that we haven't introduced this. There's been a strong population support for this for many years. Now we see also a change in the medical professionals, that there's an increased support for assisted dying in some form. So I think also that there's, you might also say, sort of a democratic aspect of this. If we don't have any extremely strong arguments against it, and we also have sort of population support, I think there are strong reasons for introducing the system.
Mm-hmm. Okay, so Dr. Sandman, just before we go, would you like to mention where people can find you and your work on the internet?
Yes, I think the easiest way to find me is at Linköping University website, leu.se, and the National Center for Priorities in Health, where you find our center and my work, and you can find links to my work if you're interested. And I'll be happy to respond if you send an email to me at lars.sandman@leu.se.
Okay, very well. So thank you so much for taking the time to come on the show. It's been a real pleasure to talk to you.
You too, Ricardo. Nice seeing you.
Hi guys, thank you for watching this interview until the end. If you like what I'm doing, please share it, leave a like, hit the subscription button, all of those things you already know. And please consider supporting the show either on PayPal or Patreon. All of the links will be in the description box of the interview, starting at $1 per month, so it would be a great help. This show is brought to you by Enlights, Learning and Development Done Differently. Check their website at enlights.com. I would also like to give a huge thank you to my main patrons and PayPal supporters: Karen Litske and Blanchett, Pererga Larsen, Lau Guerrero, Francis Ford, Hans Frederick Sunder, Ricardo Vladimiro, Craig Healy, Adam Castle, Olaf Alex, Jonathan Wiesel, Jacob Klinkby, Matthew Whittingbird, Arno Wolf, Tim Hollisey, Eric Alenia, John Connors, Paulina Barron, Philip Force Connolly, Jerry Mueller, Herbert Gintis, Rutger Vosbo, Weingard, Rebecca Newberger Goldstein, Dan Demetri, Robert Windager, Rui Narcio, Arthur Coe, Zup, Marco Neves, Colin Holbrook, Susan Pinker, Bernardo Seixas, Pablo Santurbano, Simon Colombo, Jorge Espinha, Phil Kavanagh, Mark Blythe, Roberto Inguanzo, Michael Stormir, Eric Neumann, Samuel Andreev, Tiago Nunes, Bernard Hugni, Alexander Dunbauer, Fergal Cusson, Evan Bodrenko, Al Herzog, Don Ross, Jonathan Librant, Oslem Bullitt, Nathan Nguyen, Stanton T, Samuel Correa, Eric Hines, Mark Smith, J.W., João Eira, Tom Hummel, David Sloan Wilson, Yacila Dez Araújo, Eden Solon, Romain Roach, Dmitry Grigoriev, Diego Lononio Correa, Tom Roth, Yannick Punter, Adana Rusmani, Charlotte Bliss, Nicole Barbaro, Adam Hunt, Pavel Ostazewski, Nelek Bach, Catherine and Patrick Tobin, Al Ortiz, Guy Madison, Gary G. Hellman, João Linhares, Lida Cosmidis, Sam Afzal, Adrian Yegi, Nick Golden, Paulo Tolentino, João Barbosa, Jules Price, Edward Hall, Edin Bronner, Franca Bortolotti, Gabriel Pons Cortez, Ursula Litske, Denise Cook, Scott, Zachary Fish, Tim Duffy and Trader in NYC. My producers is our web, Jim Frank, Lucas Stafiniak, Ian Gilligan, Luis Caetano, Tom Vanagdam, Curtis Dixon, João Linhares, Benedict Mueller, Vega Guidi, Sardus France, Thomas Trumbull, and Nuno Welder. And my executive producers, Michel Rugieski, Rosie, James Pratt, Matthew Lavender, Sergio Codreanu, and Bogdan Kanivets. Thank you for all.